Hey guys, it's Medicosis Perfectionatus where medicine makes perfect sense. Let's continue our pathology playlist. In the last video, we talked about cell injury and we said that cell injury is reversible, unlike necrosis or apoptosis, because these are irreversible processes. Now, do you recall what's the most common cause of cell injury, which is reversible? The answer is tissue hypoxia or anoxia. What does hypo mean? Low. What does oxy mean? Oxygen. So tissue hypoxia means that my tissue lacks oxygen. Is this a big deal? Of course, because remember that your TCA or Krebs cycle that happens in the cell requires oxygen. More importantly, the electron transport chain, i.e. oxidative phosphorylation, also requires oxygen and takes place in the mitochondria of the cell. Therefore, no oxygen, no energy. No energy, no survival. Cell injury versus death. One is reversible, the other is irreversible. This one usually happens because of an insult that came for 2 or 3 seconds and then went away. But what if that insult did not go away? Then the cell injury will become cell death. One example, if my brain lives without oxygen for 20 seconds, it can survive. But for 20 minutes, I am toast. Here's a better classification. My cell got exposed to an irritant. This depends on the type of the irritant and the type of the cell. From this, we'll have 3 responses. Can you draw this with me? If the irritant is mild, that will be a reversible injury. What do we have? We'll have some inflammation, we'll have some degeneration, some clouding, some hydropic degeneration, fatty change, etc. But what if that irritant is a severe irritant? What do you think is going to happen? Well, irreversible damage. What do we call that? We call this cell death. Oh, what do you mean by cell death? I mean it could be apoptosis, programmed cell death, i.e. cell suicide, or necrosis, cell homicide. Do we have a third option? Yes, indeed we have. We have a persistent irritant. What's going to happen here? Adaptation by your cell. Oh, what do you mean by adaptation? A new altered state. And this can include one of 2 things. 1, disturbance of growth. Okay, of course, because of a persistent irritant. And number 2 is intracellular accumulation of some gunk. What do you mean by disturbance of growth? Stuff like atrophy, hypertrophy, hyperplasia, metaplasia, or even the ugly neoplasia. How about intracellular accumulation? Could be accumulation of lipids, of carbohydrates, of proteins, of pigments, or calcium. If you do not get the big picture in pathology, you will be lost in the sauce. That's why I always urge you to watch my pathology videos in order. Remember the causes of the reversible cell injury? They included hypoxia or anoxia, chemical agents, physical agents, free radicals such as the reactive oxygen species, inflammatory causes, immunological causes, genetic causes, metabolic causes, microbiological causes, nutritional deficiencies, intracellular accumulation, and aging. What's the most common cause? Hypoxia or anoxia. Which organ do we tend to blame the most? Who's responsible for bringing oxygen into my body? The lungs. And who's responsible for distributing that oxygen all over the body? The heart. Therefore, if I have a blue baby, a baby born blue, which organs do I blame? The lungs or the heart? Could be a respiratory disease or a cyanotic congenital heart disease. Cyanotic because I have cyanosis. How can I tell the difference? Give oxygen. If it resolved the problem, it means it's a lung disease. Why? Because by giving oxygen, you're replacing the lung's function. If this corrects the issue, it was a lung problem. If this does not correct the issue, it means even though you push the oxygen into the body, there is no pump to pump that oxygen throughout the body. So it's a cyanotic congenital heart disease, as we have discussed in the previous video. What are these cyanotic congenital heart diseases? Tricuspid atresia, tetralogy of Fallot, a PVR, transposition, and truncus, don't you know? What's the definition of hypoxia, please? Inadequate tissue oxygenation. How about anoxia? Not just less oxygen, but no oxygen. An means no, as in anemia, which literally means no blood. which is not a very accurate term because in anemia you still have some blood. Can you give me some causes of anoxia? Sure. Blame the heart or blame the lungs, cardiac arrest or respiratory failure. Regardless of the cause, if I have hypoxia or anoxia, there is less oxygen going to the tissue, which means there is less oxygen in the mitochondria of the cell, which means there is less oxygen in the electron transport chain, which results in less ATP synthesis by the ATP synthase, which is part of the electron transport chain. Have you watched my video on the electron transport chain? You will find it in my biochemistry playlist. In that video, we said that oxygen is an electron acceptor in complex number 4. If oxygen is present, the next step is likely to take place. What's the next step? ATP synthesis to make ATP from ADP and P. You can download these doozy notes from my website, by the way, medicosisperfectionalis.com. But if there is no oxygen, i.e. hypoxia, then there is no ATP synthesis. No cash, no problem. Actually, there is a problem because now we have no energy. What are the causes of tissue hypoxia? Ischemia, hypoxemia, and hemoglobin abnormalities. Ischemia, blame the blood vessel for not bringing in enough blood. Hypoxemia, blame the low partial pressure of oxygen in the arterial blood. Hemoglobin abnormalities, blame the hemoglobin, which is part of the red blood cell. Number 1, ischemia. What does isch mean? Decrease, lack of. How about emia? Blood. Who do I blame? Blame the blood vessel for not bringing enough blood. Not blood is going to the heart. The heart can get angina or myocardial infarction. Not enough blood going to my brain. It gets TIA or stroke. Angina is to TIA what myocardial infarction is to stroke. Angina and TIA are reversible cell injuries, but myocardial infarction and stroke are irreversible cell injury. We cannot go back. The cells that are lost forever. She gone, man. She gone. Not enough blood going to my kidneys, pre-renal azotemia, which is an acute renal failure or acute kidney injury. There is a rule in kidney diseases that says no BP equals no PP. If I do not have enough blood pressure to perfuse the kidney will be unable to produce any urine, no PP. If you want to learn more about azotemia, refer to my nephrology playlist. I have videos on acute renal failure and chronic renal failure, as well as nephritic and nephrotic syndromes. Not enough blood going to the lungs, you get red infarction. Why not pale infarction like the rest of the organs? Because the lung has a dual blood supply, pulmonary artery and bronchial artery. Next, not enough blood going to my gut. If there is not enough blood going to the small intestine, it's called mesenteric ischemia. If there is not enough blood going to the large intestine or the colon, we call this colonic ischemia or ischemic colitis. Not enough blood going to my limb, I get acute limb ischemia with the famous 6 P's as symptoms. Do you know what the 6 P's are? Please let me know the answer in the comments below this video. One complication of this is called Volkmann's contracture. Not fun when your limb is not getting enough oxygen. Not enough perfusion to your skin, you can get Raynaud's phenomenon. You're patriotic, red, white, and blue. Not enough blood going to my liver, I get ischemic hepatitis. Not enough blood going to the biliary system, a calculus cholecystitis. Not enough blood going to my pituitary after labor and delivery, Sheehan postpartum necrosis. Not enough blood going to all of the organs is a state of shock, which is literally defined as inadequate tissue perfusion, usually accompanied by hypotension. So can we enumerate some causes of ischemia where we blame the blood vessel for not bringing in enough oxygen? Sure. What if there is something obstructing that artery, like a thrombus, a clot? What else? What if that thrombus dislodges and blocks another vessel? You call this an embolus. Hypotension with shock can do it. Arterial diseases like atherosclerosis or fibromuscular dysplasia, of course, can hinder the blood supply to an organ, leading to tissue hypoxia, because it's the job of the artery to bring oxygen to the tissue. If the artery is blocked or if it has atherosclerosis, then the artery will not be able to bring oxygen to the tissue As a result, I will develop tissue hypoxia. It doesn't have to be an arterial block. It could be a venous block as well, because if you block the vein, everything will back up and you will destroy the entire system eventually. It just takes longer with a vein blockade. What are the complications of tissue hypoxia? It's an ugly song. Atrophy, infarction, organ dysfunction. Atrophy, infarction, organ dysfunction. Do I find these after a case of stroke? Yes, indeed. Do I find them after a myocardial infarction? Yes, of course. What are the three causes of hypoxia again? Ischemia, hypoxemia, hemoglobin abnormalities. Let's talk about hypoxemia. Hypo means what? Low. Oxy means what? Oxygen. Emia means what? Blood. Less oxygen in the arterial blood, i.e. low PaO2, which is the partial pressure of oxygen in the artery. Because recall that in your arterial blood there are two types of oxygen. There is the free oxygen floating in the blood, and there is the bound oxygen. Bound to whom? Bound to hemoglobin on the red blood cell. Oh, so what are we referring to when we say hypoxemia? We are referring to decreased in the free oxygen. To get the most out of this video, please watch my video titled Oxygen Delivery and Oxygen Hemoglobin Dissociation Curve, and you'll find this in my pulmonology playlist. Remember, it's the job of the lungs to bring oxygen to the body, and then it's the function of the heart to pump that oxygen throughout your body. Here is an alveolus in the lung. Bringing the oxygen into the alveolus is called ventilation. Getting the oxygen from the alveolus of your lungs into the pulmonary artery in your circulation is called diffusion. The ability of the heart to pump that blood to the lungs in the pulmonary artery and then pulmonary capillaries is called perfusion of the lungs. Ventilation is abbreviated as V, diffusion as D, and perfusion as Q because it usually means flow. So what are the causes of hypoxemia or decreased free oxygen in the arterial blood? It could be a ventilation defect, a diffusion defect, or a perfusion defect. Back to basics. You breathe air in. This air has oxygen. Oxygen is now in your lungs, in your alveoli. Then oxygen will jump from your lungs into the arterial blood. Okie dokie. Then oxygen will leave the arterial blood, i.e. the free form, and will jump onto the hemoglobin to become a bound form. Then oxygen will leave the hemoglobin and go to the tissue. That's some gas exchange right here. And then the cell will utilize that oxygen and will dump carbon dioxide onto the venous side. The veins have carbon dioxide, but they still have some oxygen. Of course, less oxygen than the artery. And then who's going to exhale the carbon dioxide? Also your lungs. Breathe in, breathe out. Now let's call them names in a good way. Oxygen in the atmosphere is 21% of atmospheric air, and this is called FiO2, the fraction of oxygen in the inspired air, which is 21%. When oxygen reaches my alveoli, it's called P big AO2. Why big A? For alveolar. And then when oxygen goes to the arterial blood, it is still free. We call it P small AO2, small a for arterial oxygen. When oxygen jumps onto the hemoglobin, now the hemoglobin is saturated with oxygen. What do you call this? SaO2, saturated oxygen in the arterial blood. Who is saturated with whom? The hemoglobin is saturated with oxygen. And then oxygen in the venous blood is called PVO2, which is way less than the arterial oxygen, as you can see. So the partial pressure of that free oxygen in the arterial blood is 100 millimeters of mercury. How about oxygen in the venous blood? 40 millimeters of mercury. As for carbon dioxide, it's the other way around. There is more carbon dioxide in the vein than in the artery for obvious reason, that the cell will use the oxygen and then will dump the waste and the carbon dioxide onto the venous side. So the veins have more carbon dioxide than the artery. How do I remember this? Easy. 4100, 4046. 4100, 4046. You start with the oxygen first and then the carbon dioxide. 4100, 4046. When oxygen is in the alveoli, what do you call that? P big AO2. But when oxygen is in the arterial blood free, what do you call that? P small AO2. Who do you think is larger? Of course, the first one has to be larger. This is just coming from the atmosphere, fresh air. So this is slightly larger than this. 104 versus 100. The difference between the two is called the big A, small a gradient, or just the AA gradient. Normally, it should be less than 15. Here, between 104 and 100, there is a gradient of just 4. 4 is less than 15, of course, so that's normal. When oxygen was freely floating in the arterial blood, we called it P small AO2. When it decided to jump onto the hemoglobin Ka, we called it SAO2. The hemoglobin is now saturated with oxygen. Think of hemoglobin as a car that can carry 4 oxygen molecules because this car has 4 seats. When all of the seats are occupied, when the hemoglobin is occupied with the maximum capacity with oxygen, we call the hemoglobin fully saturated, giving you an SaO2 of about 99%. And that's why when we order arterial blood gas to look at your acid-base status, we look at the pH, the hydrogen ion concentration, the free oxygen in the arterial blood, and the bound oxygen on the hemoglobin. Normally, this should be 100 millimeters of mercury, and this should be around 99%. Yet another concept, oxygen content. What's that? This is not just counting the number of molecules on each hemoglobin. This is just 4. No, I'm counting the volume of oxygen combined with hemoglobin. Just one molecule of hemoglobin? No. All the hemoglobin molecules in 100 milliliters of blood. Why should I care about the oxygen content? It's a measure of the total oxygen carried in your blood. What do you mean by the total oxygen carried in my blood? I mean the oxygen that's on the hemoglobin and the free oxygen that's floating freely in the bloodstream. So to get the oxygen content, we bring the hemoglobin concentration. Normal numbers in males between 14 and 17. You can say 14 and 18. In females between 12 and 15 or 12 to 16 grams per deciliter. This is hemoglobin concentration because recall that concentration always equals amount over volume. Here's the amount in grams and here's the volume of blood in deciliters. Recall that the word deci means 1/10. A deciliter is 1/10 of a liter, i.e. 100 mLs, since the liter has 1,000 mLs. Okay, so basically you're measuring the volume of oxygen combined with hemoglobin in 1 deciliter of blood. That's precisely right. Okay, we know from experience that each gram of your hemoglobin carries about 1.34 milliliters of oxygen. That's why we're multiplying by 1.34. This tells you how much hemoglobin is in your blood, but it does not tell you how fully saturated this hemoglobin is. I could have normal amount of hemoglobin, but half the seats are empty and not carrying oxygen. Oh, therefore we have to account for the saturation of the hemoglobin with oxygen. Amazing. All of this is telling me about the oxygen that's on the hemoglobin. No one is telling me about the free floating oxygen in the blood. Who's that? That's the P small AO2. So you multiply by that. Forget this physics mumbo jumbo and let's make it simple. The oxygen content depends on 3 things and 3 things only. Number 1, hemoglobin concentration. Number 2, the SAO2. And number 3, the PaO2. Bingo. What's the normal hemoglobin concentration? I just gave you the number. Normal PaO2, 100 millimeters of mercury. The normal SaO2, about 99%. Let me tell you something. Where do you think the oxygen on the hemoglobin came from? Oh, it came from the oxygen that was freely floating in the bloodstream when it decided to jump on the hemoglobin. Exactly. So anything that decreases PaO2, i.e. hypoxemia, is going to bring the oxygen saturation down. It's called common sense. Moreover, when the oxygen content goes down, you know who's gonna suffer? All the tissues, because the tissues are not getting enough oxygen. In response, the kidney will produce more erythropoietin to tell the bone marrow to make more red blood cells. Because if we do not have enough oxygen for some reason, at least we can bring in more red blood cells containing more cars, more hemoglobin to try to catch every single molecule of oxygen possible. Conversely, anything that raises oxygen content will decrease my erythropoietin production by the kidneys. Remember, we talked about erythropoietin before. In some cases, erythropoietin is high, but you gotta ask yourself, is this appropriate increase or inappropriate increase? If this is appropriate, it means we are responding to hypoxia. We are responding to decreased oxygen content, as in cases of chronic obstructive pulmonary disease, obstructive sleep apnea, if I live in high altitudes. So remind me again, oxygen content depends on 3 factors: hemoglobin concentration, PaO2, SaO2. Out of these 3 factors, which one is the most important? Hemoglobin concentration, which normally is around 15 grams per deciliter. Please do not confuse ventilation with oxygenation. Ventilation is the ability of the lung to bring oxygen to the alveolus. If this happens, you are ventilated. But then oxygenation is different. Oxygenation is to get that oxygen from the alveolus, make it diffuse through the pulmonary interstitium or the alveolar interstitium, bring it to the arterial blood and make it jump onto the hemoglobin. Only then would we call you properly oxygenated. Therefore, what's the job of the pulse oximetry? The pulse oximetry measures oxygenation. It cannot assess ventilation. So what are the causes of hypoxemia or decreased free oxygen in the arterial blood? It could be a ventilation defect, a diffusion defect, or a perfusion defect. Ventilation defect like what? Inability to bring oxygen to the alveoli. Maybe because you're not breathing, because of opioid intoxication, because opioids inhibit the respiratory center in your brainstem, in the medulla, or because you're morbidly obese. It's not just about the rate, but the depth of breathing. Or maybe you're breathing, but the air has less oxygen because you're living on a mountaintop. It could be a diffusion defect. What could happen here? Lung fibrosis, fibrosis of the interstitium. The interstitium is filled with gunky fibers. Thick fibrous tissue. Do you think this oxygen will be able to reach the arterial blood? It's not gonna happen. And therefore, what's gonna happen to my P small AO2? It will decrease. So if I'm not breathing, if the air does not have enough oxygen, or if the oxygen cannot diffuse, either way, there will be not enough oxygen in my arterial blood. Of course, it's a piece of cake. And anytime there is less PaO2, what's going to happen to the SaO2? Well, if there is less oxygen in the arterial blood, there will be less oxygen available to jump onto the hemoglobin. So the SaO2 will also be low. So we talked about ventilation defect and diffusion defect. How about perfusion defect? Maybe I have a pulmonary embolus. Oh, even if oxygen diffuses and there is an embolus right here, this oxygen will be unable to be returned back to the left atrium of the heart through the pulmonary veins. This oxygen will never reach the heart, and this oxygen will never be distributed to your tissue. You get a tissue hypoxia, namely hypoxemia. Do you want to learn more about acute respiratory distress syndrome, cardiac arrhythmias, angina, myocardial infarction, ischemic stroke, hemorrhagic stroke, and much more? Then download my emergency medicine high yields course at medicosisperfectionalis.com. So there you have it: ischemia, hypoxemia, and hemoglobin abnormalities. These are the 3 causes of tissue hypoxia, which is the most common cause of cell injury. Let's talk about number 3, hemoglobin abnormalities. These are many, including anemia, carbon monoxide poisoning, methemoglobinemia, sulfhemoglobinemia, and put an asterisk next to cyanide poisoning. It causes hypoxia, but it's not a hemoglobin toxin, it's a mitochondrial poison. Remember your hemoglobin? Your hemoglobin is on your red blood cell. Your hemoglobin is made of heme and globin. What's the heme? The heme is made of iron and protoporphyrin. And what's the globin? Just a bunch of amino acids. You have 2 alpha chains and 2 beta chains of globin. Where does the oxygen bind? The oxygen binds to the iron. Is this iron in the ferrous state or the ferric state? It's in the ferrous state. Is this part of the heme or part of the globin? It is part of the heme. Iron and protoporphyrin are part of the heme. Where does carbon dioxide bind? It binds to the globin. Oh, amino acids then. But I know that the amino acid has a C terminus and an N terminus, a carboxy terminus and an amino terminus, hence amino acid or amino acid. Here's the amino part. How about the 2,3-bisphosphoglycerate or diphosphoglycerate? It binds to the beta globin chain of the normal adult hemoglobin, hemoglobin A. Let me tell you something very important. Your hemoglobin can either bind to 3-BPG alone or oxygen alone, but not both of them together. This is just my way of thinking about it. Which means when 2,3-BPG comes and enters into the hemoglobin, oxygen has to leave the hemoglobin and go to the tissue. Remember when I was exercising my right arm only but not the left arm? What was happening in the right arm? Metabolism, glycolysis. What does glycolysis produce? Oh, it had an intermediate known as 2,3-BPG. It was one of the detours of glycolysis. If you have watched my videos on glycolysis in my biochemistry playlist, anytime I metabolize, what's going to happen? 2,3-BPG goes up. Anytime 2,3-BPG binds the hemoglobin, oxygen has to leave the hemoglobin and be given to the tissue. Hashtag tissue oxygenation. What do you call it when hemoglobin is leaving the oxygen and giving it to the tissue? Unloading, unbinding, dissociation of oxygen from the hemoglobin and going to the tissue. When I shift the oxygen hemoglobin dissociation curve to the right, I am giving oxygen to the tissue. The right hand symbolizes giving. However, with left shift, the tissue is left behind without oxygen, because all of that oxygen will stay on the hemoglobin and will not leave the hemoglobin and go to the tissue. Again and again and again, oxygen content depends on 3 factors: hemoglobin concentration, the PaO2, and the SaO2. How much hemoglobin you have, the free oxygen, and the bound oxygen. What do you think happens in anemia? In anemia, I have less red blood cells, which means less hemoglobin concentration. So which of these parameters will change? I want you to pause and think about it. Let's answer this together. In anemia, hemoglobin concentration will go down, of course. How about the free oxygen that's floating? It's normal. How about the percentage of oxygen on the hemoglobin? Is the hemoglobin fully saturated? Yes. While it's true that I have less cars, every car is fully occupied with oxygen. So we have normal SaO2. Therefore, what's going to happen to the oxygen content? Because hemoglobin concentration went down, oxygen content goes down. That's why anemia affects and decreases your tissue oxygenation. In anemia, there is less red blood cells, which means less hemoglobin, which means oxygen content goes down. But if I have anemia and go to the hospital and they plug into my finger this pulse oximetry, what will be the result? Normal result. Even though I'm anemic? Yes. Even though I'm hypoxic? Also yes. Next, another hemoglobin abnormality is carbon monoxide poisoning. We have talked about this before in my hematology playlist. I have a special video titled Carbon Monoxide Poisoning. Look at this cherry red skin. What carbon monoxide does is that it inhibits complex 4 of the electron transport chain, which is cytochrome C oxidase. No electron transport chain, no energy for you. Carbon monoxide loves hemoglobin even more than oxygen loves hemoglobin. So when carbon monoxide shows up, the hemoglobin will tell the oxygen, I do not want to see you anymore. I found my true lover, carbon monoxide. So carbon monoxide will bind to the hemoglobin and oxygen will be unable to bind to the hemoglobin, i.e. less loading of oxygen onto the hemoglobin. Oxygen will be unable to jump. Moreover, carbon monoxide doesn't let the hemoglobin release the oxygen that was already there on the hemoglobin, i.e. less unloading, which means the oxygen that was already on the hemoglobin will not be able to leave the hemoglobin and go to the tissue, i.e. left shift of the oxygen hemoglobin dissociation curve or oxygen binding curve, and with left shift the tissue is left behind. So in cases of carbon monoxide poisoning, what do you think happens to these parameters? Let's think about this. Hemoglobin concentration does not change. The free oxygen in the arterial blood is not altered by the carbon monoxide. However, less loading will happen, which means the saturation of hemoglobin with oxygen will decrease. What do you think is going to happen to oxygen content? It will decrease. Unfortunately, this decrease in oxygen saturation is usually not detected by the traditional pulse oximetry probe. You need a more sophisticated probe known as pulse co-oximetry, which uses more wavelength to measure not just the oxy and the carbaminohemoglobins, but also the carboxyhemoglobin, and the methemoglobin as well. Speaking of methemoglobin, let's review methemoglobinemia quickly. Again, I have a separate video on this topic in my hematology playlist. You will find it in this pathology playlist as well. Normally you have hemoglobin in your blood, right? But sometimes this hemoglobin changes. What's the name of change? Meta means change. Instead of the normal ferrous, you'll have ferric. Ferrous is normal. Ferric is abnormal. Only Fe2 can carry O2, oxygen. But ferric is hysteric. It cannot carry oxygen. So, when my hemoglobin changes from ferrous to ferric, methemoglobinemia, that's a hemoglobin abnormality. You can call this dyshemoglobin. Dys means difficulty or defective hemoglobin, which is a cause of hypoxia. We just talked about the 3 causes of hypoxia, right? Moreover, do you know what the signs and symptoms of hypoxia include? Cyanosis, confusion, cognitive impairment, lethargy and fatigue, coma and death. Normally, most of your hemoglobin should carry oxygen in the arterial blood. Look at the saturation of this. 97% saturated with oxygen. Oh, oxygen is almost everything of that hemoglobin. But look here in methemoglobinemia. Oxyhemoglobin went down. And that's why my oxygen saturation went down from 97% to 50%. Because methemoglobin has entered the room, oxyhemoglobin left the chat. Unfortunately, the traditional pulse oximetry will not detect this decrease. That's why pulse co-oximetry is better than pulse oximetry. What does co-oximetry stand for? Co as in carbon monoxide. Methemoglobin is one of the forces or the factors that will shift my oxygen hemoglobin dissociation curve to the left. And with left shift, the tissue is left behind, i.e. without oxygen, meaning tissue hypoxia. Again, the pulse CO oximetry or co-oximetry is more accurate than the pulse oximetry. Pulse oximetry cannot detect methemoglobin or carboxyhemoglobin, but the pulse co-oximetry can detect both methemoglobinemia and carboxyhemoglobin. This is methemoglobinemia. This is carbon monoxide poisoning. So if you suspect methemoglobinemia or carbon monoxide poisoning, do not trust the result of the good old pulse oximetry. You will need a more sophisticated machine. Can you tell me what's going to happen in methemoglobinemia? Please pause and try to answer it yourself. Does methemoglobinemia alter the hemoglobin concentration? No. If you had 15 grams of hemoglobin per deciliter of blood, you will still have the same amount. The concentration will not change. So this stays the same. How about the PaO2? Well, methemoglobinemia did not touch the free oxygen in the arterial blood. So this partial pressure of arterial oxygen will remain the same. How about the saturation of hemoglobin with oxygen? Recall that only Fe2 carries O2, but Fe3 cannot carry oxygen, so the saturation decreases. Because the saturation went down, oxygen content goes down as well. Unfortunately, this will not be detected by the good old pulse oximeter. You will need pulse co-oximeter. What do you think is going to happen in cyanide poisoning? Have you watched my video on cyanide poisoning? What do you think takes place in polycythemia? How about in high altitude sickness? Can you let me know the answers in the comment section? You will find the answer key in the next video in this pathology playlist. Causes of tissue hypoxia are ischemia, hypoxemia, and hemoglobin abnormalities. To learn about the normal changes of pregnancy and the diseases that happen during pregnancy, including gestational diabetes, preeclampsia, eclampsia, peripartum cardiomyopathy, acute fatty liver disease of pregnancy, and much more, download my obstetrics gynecology high yields course at medicosisperfectionalis.com. To master pharmacokinetics and pharmacodynamics with all these crazy graphs and equations, download my general pharmacology course on my website. If you do not want to download my courses but would rather watch them right here on YouTube, click the join button and choose the highest tier. Please subscribe, hit the bell, support my channel here or here. Go to my website to download my courses, notes, and cases. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.